So today's topic is little different. Instead of talking about the common headaches like migraine and tension type headaches, we will talk about one of the actually uncommon headaches, not one of them, but some uncommon headaches. So we'll start with unilateral headaches. Before we start, I want to kind of talk about different definitions. So what's unilaterality and what is autonomic functions mean, what is autonomic symptoms means, okay? And then when we are defining the headaches, the headache syndromes, that it will make it easier to understand, okay? So when we say unilateral headaches, so migraine can be unilateral as well, but in migraine headaches, the unilateral shifts. Unilateral shifting headaches means that the headache can be right-sided or left-sided, but it shifts. So one time, one attack can be on right side, the second attack can be on the left side. Okay? So when we say unilateral shifting headache, so that means that headache is on, when you have the headache, it's one-sided, but it moves. So it can be on right side or on left side. But when we say unilateral locked headache, which means that it's either right side or it's either left side, it doesn't move. So if person has a headache on right side, it's on the right side 20 years, 30 years. It doesn't move, okay? Or it's on the right side for a year, it's on the left side for second year, okay? For that year, it's locked to the right side. For second year, it's locked to the left side. Usually, migraine defined as unilateral shifting headache. It's more than 99%. Migraine is unilateral shifting headache. If a headache becomes unilateral locked headache, we always think about it, something else is going on. Maybe it's not migraine, maybe something else is going on, like a structural disease. Okay, so that's one terminology that will be important. The second thing is autonomic symptoms. So when we say autonomic symptoms, means that we are talking about symptoms like tearing from eyes and runny nose, redness of the eyes, and droopy eyelids, or swelling of the face. If this symptoms happening on one side, that might be different headache, one-sided. Okay? Migraine, sometimes migraine can go with autonomic symptoms. Sometimes migraine people can say that I have tearing from both eyes, I have redness on my both eyes, or my eyelids get swollen when I have a migraine. But it happens both eyes, okay? Those symptoms are also important because sometimes different treatment options will be available for those patients, okay? But if they are one-sided, it's very important to mention to the doctors. Sometimes it's very important for doctors to ask to the patients, but sometimes it can be missed. So it's very important for patients, if they are experiencing these symptoms, to tell their patients that I am having these one-sided symptoms with these one-sided headaches. because it's not migraine, it's not tension headache, it's a different headache syndrome and it needs different treatments. Okay? Any questions about this terminology? We talk about what's autonomic syndromes, what's autonomic symptoms, tearing from eye, runny nose, redness of the eyes, droopy eyelids, or swelling of eyelids, or swelling of the face. And we talk about what's shifting, unilateral one-sided shifting headaches, or what's unilateral one-sided locked headache. Locked means headache is only on the right side or only on the left side. Shifting means headache can be on the right side or the left side, it moves. Okay? Are these clear and simple? Any questions about this? No? Okay. So the most common unilateral headache is cluster headache. Cluster headaches most common in male patients. It's male predominance, but it doesn't mean that it doesn't happen in females. So this year I had 2 female patients that they had cluster headaches. It's not common, but it can happen. Okay? It's rare on females, it's most common on males, but it can happen on females as well. So one of the specific for cluster headaches that it's seasonal. So during fall or during spring, we see more cluster headache patients than during summertime or winter time. We don't see cluster patients for a long time, like we don't see them summertime, we don't see them winter time, and then all of a sudden we start seeing cluster patients. It's seasonal. It starts as a seasonal, and then they start having these attacks of one-sided headaches, and then it's kind of subsides. They don't have headaches for a couple months, and then again, either fall season or spring season, whatever it's next, then the headache comes back. So during those seasons that they can have one-sided headache, which will be locked to one side, and the next season it can change to other side. So one season it can be right side, but it will be always on the right side. Second season it can be left-sided, it will be always on the left side. It won't change during that season. So that's why it will be one-sided locked headache. It is one-sided locked headache with autonomic symptoms. So patients will come with suffering from one-sided headaches that usually starts in spring or fall time, and they will have this runny nose on one side, not the other side, only on the one side, and the same side of the eye will have tearing, same side of the eye will be droopy eyelids, and the same side of the eye will be red, and they might complain about dullness sensation on that side of the ear, and they might have swelling of that side of the face during the attack only. And the attacks can last from 30 minutes to 180 minutes. It's very severe headache, and one of the main difference between migraine and cluster headache, when you have migraine, you don't like to move. When you have migraine, you lay down in a dark, quiet room and you don't move. When you have cluster headache, you cannot sit still. You just keep moving. They often say that they keep hitting their head to the wall. It's called suicide headache. It's so severe headache that they don't know what to do. They think about suicide. It's very severe headache that needs to be taken care of very quickly. You cannot tell the patient to wait to see me 3 months later. they need to be seen quickly, within a couple days. That's very severe. Okay, so the attacks last within 30 minutes, but it is very severe. The other things, attacks happens in specific times. So they will get the attacks always at the same time. So they will say that they always get the attacks like 12 a.m., 3 a.m., 1 p.m., and 4 p.m. I'm just making about this time. So it will change based on the patients. Every patient will have their attack time. But it will be around the clock, and it will be same time with for that patient.
Is it pretty typically multiple times a day?
It was yeah. Usually it's multiple times a day. Usually they will have one or couple attack at night. Okay. But they will also have attack during the day as well. Okay. And the headache gets first with alcohol, which is same thing happens with migraine as well. Okay. And the treatment, usually it's very easy to diagnose. Usually doctors makes very good thing. I mean, ERs or any primary care physician, it's very easy to recognize, especially if patient is a male patient. It's very kind of specific headache type, get diagnosed very easily. Treatment is very specific. Oxygen helps a lot for these patients, but it needs to be with a non-rebreather mask. So the problem usually we face with is they get treatment with nasal cannula, and nasal cannula doesn't help. They need high flow oxygen with non-rebreather mask. It's a specific mask that gives high percentage, like 100% oxygen. With nasal cannula, they don't get enough oxygen to stop their headache. So it's a high flow oxygen, 10-15 milliliter, and it's with non-rebreather mask. It's a specific mask. It has to be full face non-rebreather mask and 10-15 milliliter oxygen. If it doesn't help, then it will be sumatriptan or Imitrex injection. So the other things, sometimes they get prescribed with Imitrex or sumatriptan tablet, but it takes too long to tablet kick into their system, and by the time that the headache will go away. So they need Imitrex sub-Q injections. So that's one thing they face with, is that insurance doesn't give enough sumatriptan injections. For that season, they need multiple injections because they cannot carry oxygen with them when they are outside. When they are driving, it might not be safe. So they need the sumatriptan injections, but they cannot get enough to go through that season. So we end up giving sumatriptan injections through the year. They end up filling it through the year so they can have enough when they have their attacks.
What about the sphenopalatine ganglion
Block.
block?
It's not for sure, but it can help maybe. But it's not like a cure for cluster headache. So there are new, okay, so if it is episodic, then these are the treatment. But what if it is chronic? It can become chronic. The other things, it can help to kind of shorten the duration of the attacks, duration of episodes, is prednisone. So we can use Prednisone Taper. So the important thing is for Prednisone Taper, so these treatments are known. So oxygen therapy is always known, but the problem with nasal cannula, it should be mask. Sumatriptan is known that prescribed is a tablet, it should be a sub injection. Prednisone is known therapy, but the problem is it starts with low dose. Low dose is not the option, it should be high dose. It should be start at least 60 or 80 milligrams. a headache diagnosis for one-sided headaches. When it becomes female, the main headache diagnosis for one-sided headaches for females is paroxysmal hemicrania or hemicrania continua. So the only difference between paroxysmal hemicrania versus hemicrania continua is paroxysmal hemicrania is episodic, hemicrania continua, it becomes continuous, like more chronic headache. Okay, so it's more female than male patients. I never seen a male patient who has this disease. And again, it's one-sided headache with it's a locked headache, never happens on the other side. It's one-sided locked headache, never goes on the other side with autonomic symptoms. The problem with paroxysmal hemicrania or hemicrania continua, the autonomic symptoms can be very subtle. So they might not have that severe autonomic symptoms like cluster headache patients. They might have only like maybe a little bit tearing. They don't really pay attention to that because it doesn't really bother them a lot. They might have little bit droopy eyelids that if they don't really look at the mirror, they don't pay attention. Or they might have only light sensitivity worse on one side than the other side. And because of the light sensitivity, because they are closing their eyes, they don't really see the droopiness. So sometimes with intractable migraines that nothing is working for their migraines to our patients, then when we are kind of re-evaluating them, are we missing something? We made this migraine diagnosis, but are we missing something? Because nothing is working for this patient. What we do is, when we go back and then kind of question our diagnosis again, if the headache doesn't really move, it's always on the one side, then we ask patients to kind of close one eye and then check the light sensitivity. Then they might realize that light sensitivity is worse on the side that they have the headache and not really as severe on the other side. Then we might consider doing a medication trial called Indomethacin. I'm hoping one of them will write. Okay. Indomethacin. So it's how you diagnose and how you treat. So you start indomethacin with 25 milligram 3 times a day. And you increase it to 50 milligram 3 times a day. So 25 milligram 3 times a day is not really for the treatment. It's for to see if they can tolerate it. If they tolerate 25 milligram 3 times a day, then you increase it to 50 milligram 3 times a day. And if they see some improvement, the headache, it's helping for the headache, but not quite sure, or they would like to have some more improvement, then you can increase it to 75 milligram 3 times a day. It's the maximum dose. So then, and then it stops the headache, that's the diagnosis and then the treatment. So the problem with indomethacin is a non-steroid anti-inflammatory. So it belongs to the same group with ibuprofen or naproxen. But it doesn't really only work the same way that ibuprofen or naproxen works. That's why there are a group of headaches in headache literature that they are called indomethacin responsive headaches. So there are a group of headaches that they only respond to indomethacin. Indomethacin really works for those. It has some chemical effects on dopamine receptors, and that's how we think that it helps for this kind of headaches. So there are other mechanisms other than being non-steroid anti-inflammatory. Okay? But because it's also non-steroid anti-inflammatory, it can be hard on your kidneys or it can be hard on your stomach. So we have to be careful. If someone is having kidney problems, we cannot really use high dose of indomethacin. So it has some limitations. Or if someone is having stomach problems, we have to be careful with indomethacin. We have to consider maybe some medications like pantoprazole, PPIs to protect stomach, or maybe we should consider using low dose, or we should not use indomethacin and we should consider some other medications after diagnosing the headache. Okay. So that's the way we diagnose it. So indomethacin trial is the way we diagnose paroxysmal hemicrania or hemicrania continua. If a headache responds to indomethacin, then that headache is paroxysmal hemicrania. If it is a chronic headache, then the diagnosis is hemicrania continua. Okay. So the paroxysmal hemicrania attacks can be a little bit longer. And then when it becomes hemicrania continua, it kind of becomes chronic, not like an attack. Okay? But again, it's one-sided with tearing from one eye, redness of one eye, droopy eyelids, dullness sensation on one ear. Sometimes you don't really see those very specific, and the only thing you might see is very kind of severe light sensitivity on one side with the headache, but not very severe light sensitivity on the other eye. That can be very subtle difference with one-sided headache, and then with the indomethacin trial, you see that it's helping. That's your diagnosis. It's not the migraine. That's why nothing helped. Okay. Any question about this? just primary. She had this headache for 30 years. And she had a surgery for trigeminal neuralgia, which didn't help because it wasn't the diagnosis. And she was about to suicide. So it was that severe. She wasn't able to eat, she wasn't able to sleep. So it's really severe headaches. But it's very rare. So it's important to know that even if it is rare, it can happen. Okay? So the treatments are different. So for these headaches that we can try, because kind of it can be female, it can be male. Is it cluster? Is it Indomethacin? So what I usually do when they come to see me in my office, then I try oxygen directly in the office, so that it helps me directly ruling out or just making sure that oxygen is not helping. The second thing I can do with Indomethacin trial, just making sure, because when it becomes chronic, because these headaches can be chronic, and then at that point you are really not sure if it is seconds or it's kind of like it becomes now chronic headache that it's lasting longer hours, or is the headache of this or it's like one of this. So then you can do some Indomethacin trial, but it won't help. So you can try some seizure medications, anti-epileptic. Anti-epileptic medications can help, like Lamictal or Lamotrigine, Topamax, Topiramate, Depakote, valproic acid kind of medications. But usually they don't help. The therapy usually helps, most likely to help, is IV lidocaine. So that's kind of the main things usually helps. Okay? So it's rare, but when it happens, it's very painful and it's important to diagnose. It's everything, like migraine. Is it easy to diagnose? Can be. Everyone gets diagnosed with migraine, but it's important how you get treatment, and then there are differences between person to person, right? So, but sometimes for these diseases, because they need different medications, so it's important to understand that it's different disease, different headaches, that they need a different approach. Okay? It's not because we are not minimizing other headache diagnosis, other primary headache diagnosis, but these headaches needs different approach. Okay? Migraine can be life-threatening. Migraine can be a suicide headache as well. Tension type headache can be a suicide headache as well. But these headaches, because they peak very quick, and when they start, they become very peak, and they become very severe at the onset. That's very important to kind of help them right away. Okay? Any question about this? Okay. So we kind of talk about the young people's headache. So the old people can have their own kind of headaches too. So there is one very specific headache called Hypnic Headache. Have you heard about Hypnic Headache? So it's usually after age 50. It only happens about 45 to 1 hours after falling asleep. They fall asleep and they instantly wake up with a headache. And it takes about 1 to 2 hours for them to go back to sleep again. It doesn't happen during the day unless they take a nap. And usually they said that they don't take a nap during the day, but sometimes they get a headache because they are sitting in the chair, either they are reading or they are just doing nothing, watching TV, they kind of like little bit dozing off, and then they get a headache and they woke up. Otherwise, when they are right awake, they don't get a headache. Only happens when they are kind of a little bit sleepy, or when they are sleeping at night, 45 to 1 hour after they fall asleep. So there is no there is no other way to diagnose it. It's with history, as most of the headache diagnoses. Oh, by the way, with those Seniha headaches or cluster headache or paroxysmal hemicrania, hemicronia, continua headaches, we have to do MRI and MRA. The imaging has to be done, because sometimes for young ones, different structural problems can present with those kind of headaches. So the imaging has to be done. Okay, and same thing for hypnic headaches. Because it's a headache after age 50 years old, we should always do an imaging, make sure that we are not missing any structural disease underlying the headache diagnosis. Okay, it's for every rare headache diagnosis. Okay, and the treatment for this headache is caffeine. So usually we say no caffeine for everybody, right? Especially after afternoon. Don't take any caffeine because you cannot fall asleep, and not falling asleep is not good for headache. But specifically for these headache patients, they are the only population they can go to sleep after they have caffeine. That's the treatment. Cup of coffee or a bottle of Coke, whatever caffeine they like. If it is not enough, so one of my patients, the prescription I gave for him was Mountain Dew. Even though his wife didn't like it, but he was very happy with my prescription. So, but then in the end, because he was kind of, it was a risk of gaining weight, so we decided for caffeine tablets. So we can do 100 or 200 milligrams caffeine tablets. So it's always like less is better. So we can try with less, like 50 and 100, and then try what's the dose needs to be done and what's the dose is enough. If caffeine is not, it's not helping, or it's helping at the beginning but it's not working anymore, then again Indomethacin can be the medication of option. So because these are older populations, Indomethacin can cause side effects, diarrhea, stomach problems, or these are the people that they can have kidney problems. They might not tolerate it, or they might have some side effects that they cannot take Indomethacin, some cardiac problems or other things. So then we can try other medications, but the options are very limited. There are kind of a couple review articles that you see the medications had been tried, and then you kind of smile, oh, there are options, but then when you see what happened with those medications, it's like didn't work, didn't work, didn't work, didn't work. One thing really worked is lithium, but the problem with lithium is has a very wide range of side effect profile. So we have to do EKGs and all those stuff. So when I start caffeine, I pray that it will work. So that's the best thing. If it works, that's great. Okay. If not, the second option is Indomethacin. Then sometimes we try other things that maybe Topamax can work if we are lucky. Or we talk about lithium, but if the discussion is the patient doesn't want to try it, if it is high risk, then we kind of try other anti-epileptic medications and kind of try to get away from lithium and then see if something else we can find that it works. Okay? So that's another kind of weird and rare headaches. Okay? The hypnic headache patient, usually they don't have any autonomic symptoms. The headache can be usually bilateral. It's not unilateral, it's usually bilateral. and they don't have any autonomic symptoms. They wake up and then they kind of suffer from headache, and then they go to bed, and then after 1 or 2 hours later they can fall back to sleep. Okay? Any question about this?
I just have a question about medications. You say some medications can cause stomach or kidney problems, and we're encouraged to drink lots of water. Does it help to drink the lots of water to help the kidneys and the stomach, or?
It does. We have to be careful. So it's just based on the population. Because when we are talking about the age above 50, then it changes. When we are talking about, like when we talk about migraine, I don't really mention that much about kidney problems, because usually we are talking about young female patients. But when we are talking about age above 50, even we mention about like hydration, it becomes a little bit more difficult. That we have to be careful about following up their kidney functions, maybe doing kidney function tests every 6 months. So just to mention that we have to be careful about it, and we have to be thoughtful about it. It's not mean that it's not doable. We can do it, but we have to be careful, and we have to have a discussion with our patients. Okay. Any question so far? Any specific headache that you want to talk about? Okay. There is one more headache diagnosis that I want to talk about, because it's important for any kind of headache. Any kind of headache patient needs to know about. It's called RCVS. Especially migraine patients who has migraine with aura needs to know about this RCVS. It's reversible cerebral vasoconstriction syndrome. Okay, do you want me to write it down? So, bad things can happen to migraine patients as well, right? When we are talking about our medical students or neurology residents, or when we are giving like lectures about headache, that's what we always mention. That's why we always say that just listen your migraine patients. And you guys have to be careful, again, when you are talking about your migraine, you are the one who is feeling the pain. So you have to be very clear about what you are telling to your doctor. If you are feeling like the pain is different, you have to be very clear about talking about that mentioning that this is not my usual migraine. I have migraines, but I never had a headache like this. I never had this severe, right? Because bad things can happen to migraine people. So, reversible cerebral vasoconstriction syndrome, as it says, it's reversible. What happens is the cerebral blood vessels, they vasoconstrict, they constrict, they constrict, and then it's kind of like having a mini stroke. It might end up causing a stroke. It might end up not causing a stroke, just causing like a TIA, like a transient ischemic attack that doesn't cause permanent symptoms. Okay, so sometimes that people call it mini stroke. You have the symptoms, but when you do the MRI doesn't show any structural changes, because you had maybe little thrombus that kind of went to the arteries and it blocked it, but it didn't block it long enough to cause brain damage. So then you had the symptoms, but then it went away because it didn't cause long time lack of oxygen to the brain parenchyma, brain tissue, so brain tissue didn't die. It suffered, but it didn't die. It's still alive. Same thing, the blood vessels constrict and brain feels the lack of oxygen, but then when it reverses back, that brain gets the oxygen back, so it doesn't cause a permanent damage, so the symptoms reverse back, okay? And we cannot diagnose it looking back to the MRI or MRA. It can be diagnosed during that second, during that minute. The problem is if it happens that moment and we cannot catch it, and if it happens again, maybe second time, it might end up causing a stroke. So it's important to catch it when it happens, so then we can prevent a stroke happens later. Okay, is it clear? Was I able to explain it? Okay. So it presents with a headache called thunderclap headache. Thunderclap headache is like a peak, very severe, like an ice pick headache that comes out of the blue, very severe, just hits you. You might have migraines, but your migraines kind of gets with, you kind of know that it's coming. Even your migraines hits you, you kind of understand it. It hits you within a couple seconds or minutes or whatever, right? Or you might be having some aura that you know that it's coming. Or it's kind of like starts and boils up sometimes, okay? But these ones just hits. In seconds, out of the blue, you get this very severe headache. You don't know what's going on. All of a sudden, you had this very severe thunderclap headache, okay? If it happens, that you should know that something else is going on. And that's the headache you should go to ER and then say that this is a headache I never had before, and I might be having this. That's the key word. If you tell that word to the ER doctor, they know what to do. Okay, so to be able to diagnose this, that you need MRI and MRA. So there is a full protocol for this. Okay. So it's important. If we do MRA, maybe if you come to see me 1 week later and I had the headache like a week before and I didn't know where did it come from, and that's what happened, and if I do an MRA, I might not see anything. Everything might be normal. Or you might see a stroke that happened that night. Okay. I'm not trying to scare you. Okay. It doesn't mean that it will happen, but it's some term that you should know, and just in case if it happens that it's something different. If it is your usual migraine and you have your rescue therapy, you know what's going on. You have to understand your migraine, so you know when to go to ER, you know when not to go to ER. But if it is something happening like that and you feel like, and then if you have plus this thunderclap headache, you have some neurological symptoms. What kind of neurological symptoms it can be? Like stroke-like symptoms. Weakness on one side, not being able to speak, slurred speech, droopness on your face, okay? Any stroke-like symptoms happens, plus thunderclap headache, that needs to be taken care of in the ER. And that's the word you should say that I might be having this, okay? Or the people around you if they are having something like that, or stroke.
So, does it mean you're having a stroke if you have slurred speech or it's hard to speak sometimes, or can that be part of a migraine headache symptom that's not stroke related?
If you are someone, you have complex migraines, that's how your migraine present all the time, you don't have to go to ER all the time. But if it is happening the first time, you have a right to go to ER if it is happening the first time.
Okay.
Just to make sure that it's not this. It doesn't mean that it's end up having stroke all the time. Okay? That's why it's called reversible cerebral vasoconstriction syndrome. It can be reversible one-time episode that it doesn't end up having stroke. Okay? But if you are having complex migraines or if you are having hemiplegic migraines, that's different. You don't have to go to ER every time when you have those complex migraine symptoms, because that's your migraine, that's how it presents. Okay? Do you have complex migraines? Okay, understood. Yeah. So yeah, hemiplegic migraine or complex migraine is another kind of amazing thing. It's very fascinating, and it goes based on, so it's very important what's the difference between stroke and what's the difference between complex migraine symptoms or hemiplegic migraine. So you should know about that. So stroke symptoms comes quick, out of the blue, all the symptoms together. If you are having a stroke, you will get weak or numb or speech problems all together in same seconds. That you will feel slurred speech and droopy face, weakness on the arm, leg, same seconds. If you are having hemiplegic migraine or complex migraine, you will start feeling a little bit tingly or numbness or weak on your thumb, and then kind of moves to your fingers, and then kind of moves up, goes to your shoulder or to your face, and then moves down to your feet. Some kind of progression. Okay. The theory behind of complex migraine or hemiplegic migraine or migraine are called cortical spreading depression. So within minutes, the electrical activity spreads. By that spreading depression, that your symptoms moves on your body. So if your symptoms are kind of moving and progressing within minutes, that's not stroke, that's your migraine. But if it is happening this different, all of a sudden everything happened, that wasn't your migraine usually, then you might consider going to the ER, questioning that this was different, am I having a stroke? Okay, that's important. And again, no one can say that difference, no one can call that difference. You will be the one who is telling the doctor, saying that this was the difference because this is the difference, that my symptoms usually will happen within a couple minutes. This time it happened same second. Okay, yep.
What is the treatment then if you're having this RCVS?
RCVS. So if you are having RCVS, so then first we have to make sure that you don't have any like high cholesterol, high blood pressure, everything needs to be taken care of. And then there are specific medications like verapamil, calcium channel blockers, they can help. And then also baby aspirin, it will be a protective to prevent strokes kind of symptoms. So, and then if you have stroke, that's different story. Then if there is any thrombus or any other things, that there's different story. But usually kind of like verapamil, like hemiplegic migraine, verapamil and baby aspirin will be the treatment. Okay. Any questions? Okay. We have 7 more minutes, or we can start to yoga sessions maybe. Okay. Good. Perfect. Okay. Thank you.